is your question? Right, so if you have read and understood, considering the clinical examination session, can you begin?
I'll enter the room. I'll wash my hands. And I'll introduce myself. Hello, I'm Dr. Karma, one of the exam candidate. May I confirm your name and age, please?
Yes, Tom, 67 years old.
Hello, Tom. Today I've been asked to examine your heart, which will involve looking, feeling, and listening to your heart, and also moving your upper and lower limbs, your arms and legs. Are you okay with this?
Yes.
Okay, thank you. So to begin with, I'll need you to remove your gown. I'll expose the patient's chest and
Yes.
abdomen. Then Tom, I'll just start by looking from the end of the bed. I'll look for general build, any chest deformity, movement of the chest. Now I'll come beside the bedside on his right side. Then Tom, I'll now have a look at your hands. Can you show me your hands? So I'll look at his hands on the palmar and dorsal aspect. I'll check for any signs of infective endocarditis like genuine lesion, ocelot nodes on the nail. I'll see for splinter hemorrhages, clubbing, tar staining, and then I'll feel his pulse. Now I'm going to feel your pulse, Tom. I'll feel the radial pulse, radial delay. Now, Tom, I'll have to do a test known as collapsing pulse. So I need to move your arm. So do you have any pain at the moment in your shoulders?
No.
Okay. So I'll just feel the radial pulse and then suddenly raise his arm above his head and see for collapsing pulse. Then I'll feel the brachial pulse. And I'll go to the neck, and in the neck I'll see the neck veins, JBP. I'll see the JBP, and then I'll also palpate the carotid pulse, and then I'll also see the trachea. Then coming to the face, Tom, I'll have a look at your face now. Can you look straight? Then I'll see for zentralisma or corneal arcus around the eyes. Then I'll Tom, can you look up for me? I'll check for pallor. Then Tom, can you open your mouth? I'll check for oral hygiene, dehydration, or central cyanosis in the mouth. Now, Tom, I'll have a close look at your chest now, okay? On the chest, on the inspection, I'll see for any chest deformity, any engorged veins, any visible pulsation or visible apex beat, and I'll see for any scar mark. Tom, can you raise your hand?
What do you expect to find over there?
Here, in case of pacemaker, I'll see a left infraclavicular scar.
Yes.
Which will give me an idea that he might have undergone a pacemaker placement.
Yes. Remember to mention that. Yes.
Next. And Tom, now I'll feel your chest. I'll palpate. Do you have any pain at the moment? Before I begin?
No.
Okay. Thank you. So I'll begin with the palpation of the apex pit. I'll use my fingers and then place on the left side of the chest, and I'll feel the apex pit and count from the second intercostal space and see in which space it lies.
Yes.
Then I'll feel for the hips. Then I'll feel for the thrill on all the three, in all 4 areas of the heart, and also in the carotid area. Then Tom, I'll listen to all the 4 areas of the heart for any abnormal heart sound, any murmur, and then I'll listen with the bell of the stethoscope on the carotid.
Yes.
And then Tom, now I'll have to when auscultating, I'll also feel the carotid pulse to see which if there's any murmur, what kind of murmur is that. Then Tom, I'll have to now here listen to the back. Can you sit up for me? Then I'll auscultate his lung bases. And at the same time, Tom, I'll have to test your lower back. I'll see for sacral edema. Now, Tom, I'll just have a look at the leg. Do you have any pain at the moment in your legs?
No.
Okay, I'll feel pedal edema, and I'll also feel for calf tenderness, and also look if there's any scar mark for venous graft harvest. So Tom, I'm done with my examination. Thank you for your time. You may dress now. Okay. To complete my examination, I will also check his blood pressure.
Yes.
And do a complete peripheral vascular examination.
Good. Okay, you've got just 10 seconds left. Can you present your case now? Can you present your examination?
Yes, today I've examined Tom, 67 years old, elderly male, who has been placed on the list for elective right-sided inguinal hernia with a history of pacemaker placement with mild heart failure. On examination, I found that there was a left infraclavicular transverse scar, and on examination of the chest, I found that he had raised JVP. He has pedal edema, and also and there were no abnormal heart sounds, and there was a and the lung bases were normal.
Yes.
And the rest of the examination findings were normal.
Pacemaker was there, so you have to mention that.
Yes, scar I mentioned.
Okay. Yeah. Now, all right. So, what are your differential diagnoses?
From the examination finding, my differential diagnosis will be heart failure.
Yes.
Right heart failure.
Yes.
Which is evidenced by bipedal edema and raised JVP.
Yes. Anything else you would want to rule out?
With pacemaker in situ.
Yes.
And also, I'll also rule out congestive cardiac failure.
Okay. All right. Can you please tell me if you can read this ECG? What are these circles and what are these two arrows pointing at, please?
This looks like pacemaker spikes, ma'am.
Yes.
Pacemaker spikes.
How would you describe them? Pacemaker spikes, but how would you explain them? So they are artificially induced electronic stimulation that
paces the patient's rhythm, causing a blip or spike on the ECG waveform.
So why? All right, okay, that is AVR and then AVF and V2. All right, okay. All right, can you tell me how do you intend to, investigate this patient, because this is a pre-operative and patient, and it's scheduled for
Yes.
elective hernia. So
Uh,
how do you, yes,
I'll do a baseline ECG
yes,
and also do an echocardiography preoperatively, and also do a chest X-ray, and also send his blood for PT-INR if he's on warfarin.
okay. So how do you intend to take care of patients' anticoagulation?
I'll always I'll follow the local policy, ma'am, and also
Yes.
take the advice of the hematologist.
Yes.
The basic management is if he has low thromboembolic risks, I'll stop his warfarin 5 days pre-op, and then start back up once he can post-op once he can tolerate orally. If he has high thromboembolic risks, then I'll stop his warfarin 4 days pre-op and start on low molecular weight heparin, which I'll stop 12 to 18 hours pre-op and then restart after 6 hours post-op, after assuming the hemostasis had been achieved. Then I'll restart the warfarin once he can tolerate orally, and then stop heparin if when the INR is within the range.
Okay, since the patient has pacemaker, who would you involve or who would you inform about it?
I'll involve the anesthetist and the consultant surgeon.
Anesthetic. Okay. Right. Can you quickly tell me a few indications for pacemaker? Why this patient might have had pacemaker on the first place?
Some indications of pacemaker are if the patient has symptomatic sinus bradycardia, SA nodal disease, and symptomatic AV nodal disease, and in case of hypertrophic obstructive cardiomyopathy, in DCM dilated cardiomyopathy, in long QT syndrome.
Good. Okay, thank you. One thing that I wanted to say, you did tell me that it has pacemaker spikes, and also you have to note that there are no P waves. Right, and at the end, can
Yes,
we
ma'am.
just quickly revise or go through the indication, the differential diagnosis? One you said that could be heart failure. Then 81 could be
Yes, ma'am.
endocarditis, infective
Yes,
endocarditis, and
infective endocarditis.
third, because at least 3 to 4 you have to tell.
It could be
Third, you said congestive heart failure. What else? Like you have to think and say 3 to 4 examples, 3 to 4 differential diagnosis to cover it. Okay. Good, thank you.